Thank you very much. You have heard about the medical therapy, but when everything fails, we are left with the surgical management only. Surgical management is not to treat the disease per se, it also has to be treated the underlying causes. How we are going to proceed? In the eye, in dry eye, whatever tear is there, first of all we will want that tear will be retained. This can be achieved by punctal occlusion. Then whatever tear is there, it should not evaporate it. Therefore, if we can reduce the surface area, that can be achieved by teratherapy. Otherwise, we have to include the tear enhancer. This can be done by conjunctival transplant, amniotic membrane transplant, which Dr. Raju has elaborated quite a lot. Limbal stem cell deficiency treatment, that is limbal cell transplantation, that for very severe disease, and more severe than that is mucous membrane graft is also advocated. Coming to punctal plaque, this also has been shown by earlier speaker. These are the small collagen or silicon cylinder that is inserted into the punctum to reduce the drainage of tears. It can be of two types. It is already discussed, that is temporary or permanent, depending upon the severity of the disease. Next is amniotic membrane transplant. As we know, amniotic membrane serves as a transplanted basement membrane. It acts as a new healthy surface for proper epithelialization. It prevents epithelial apoptosis. Thus, finally, it creates a healthy stromal bed and basement membrane, which subsequently support limbal epithelial stem cells. Coming to the stem cells, it occurs usually in a severe case of dry eye. Stem cells contribute to the body's ability to renew and repair its tissue. Limbal cells deficiency causes corneal opacification and leading to blindness. The repopulation with stem cells may occur by transplanting the limbal tissue. There are different types of stem cells in the body, and limbal stem cells are multipotent type of cells. How we are going to diagnose a case of severe dry eye or which has led to limbal stem cells deficiency? By loss of normal limbal anatomy. First of all, we see that there is no limbus can be defined. Then second is conjunctivization of the cornea with conjunctival and metaplastic cell, thinning and irregular of corresponding corneal surface, and superficial and deep vascularization. Vascularization is the hallmark of any severe limbal stem cells deficiency. We have to know about the grading of limbal cells deficiency. It will help us for both therapeutic and prognostic point of view. Grade 1 is little or no stem cells loss. Grade 2 is subtotal stem cell loss. Grade 3 complete stem cells loss, and grade 4 is complete stem cells loss plus loss of proximal conjunctival epithelium also. Then, as I said, the option is if it is partial or if it is total. If it is partial, it can be managed by amniotic membrane transplant or conjunctival autotransplant. If it is total, limbal stem cells transplant is the only answer. When we are speaking about limbal stem cells transplant, it can be the donor tissue can be harvested from the autogenous or allogenous. Auto can be of both can be either segmental or culture. Like auto is, we can get it from the same eye or fellow eye of the patient depending upon the extent of the disease, and allo is from the cadaver eye or family related donor, and for both it can be either segmental transplant or cultured stem cell transplant. Then we go one by one how we are going to do the segmental transplant. First of all, we have to do the peritomy depending upon the area of involvement. Then whatever the fibrovascular pannus is there, we have to dissect very carefully, and then segmental graft will be placed over the limbus, and either it has to be sutured or it can be fixed with fibrin glue, as you are seeing in this video. Why we have to go for the culture limbal stem cells? If we are seeing that segmental is good enough, we can take 2 segments. And why culture? As we know, when we are getting the allograft, it runs risk of immunological reaction. If you are taking segment more than 2/3 of the total, then it also runs a risk of stem cells deficiency. Therefore, we have to take, if we can do culture stem cells transplant, it will be much better. Biopsy is substantially smaller tissue we require for that. It is a very good method. It reduces risk of allograft rejection because due to the absence of antigen presenting Langerhans cells in ex vivo culture limbal epithelial cell graft. Then what are the carrier? If we are planning for culture stem cells transplant, what are the carrier there? Usually or routinely, conventionally, we use the biological amnion as a carrier. Otherwise, one can use also fibrin gel, contact lens, and more recently, human hair also has been used as a carrier. There are 2 types of culture method. One is explant culture system, other one is suspension culture system. When we are talking about explant culture system, amniotic epithelial cells are killed by cryopreservation and are then removed by enzymatic digestion, chemical treatment, then physical scraping of the membrane prior to use. Suspension is, it employs the enzymatic dispase which digests basement's membrane collagen and separates epithelial cells from the stroma. This separates clumps of limbal epithelial cells into a suspension of single cells. This is the only difference. Then once it is cultured, it is in the refrigerator, so we have to evaluate it frequently, and we have to see the growth over the amnion. Here is the culture stem cells transplant. Method is just same for the recipient bed. Only thing, you have to spread that amniotic carrier where the growth has occurred, and you put it over the surface. Again, either you have to suture it or you can use the glue also, fibrin glue. Post-operatively, topical on-preserved steroid and a broad-spectrum antibiotic should be given in all the cases. It should be continued for 1 to 3 months. And patients receiving allogenic cell transplant, both topical and systemic cyclosporin to be given. Then last one is mucous membrane transplant. It has been introduced by Klein in 1876. Why it is indicated? Because the epithelium is similar to corneal epithelium. It is autograph material and it is readily available. Then surgical technique is same as your limbal cell transplant, except that instead of limbal stem cells, you have to get the buccal mucosa and you have to put it over the area. The hypothesis how it works, the success of ex vivo expanded oral mucous membrane epithelial cell transplantation, it occurs due to the presence of stem cells. These cells may act as a reservoir and generate a progeny of different epithelial cells that cover the cornea. As I said, it is a very simple technique and it is much less expensive technique. It is directly, it is autologous, so chances of rejection is also less. Then what is the guideline we have to see? It is based on the type of severity of the dry eye. This guideline is for limbal stem cell, any surgical management. Based on the type of severity of the dry eye, we have to select the technique. Always it has to be considered after controlling the inflammation. Then third thing is we have to start with a less invasive procedure first, followed by, if required, the other extensive procedure. Several simultaneous measures also can be given, like limbal stem cell transplant and keratoplasty can be done also simultaneously. If there is a severe dry eye, very severe with semiliferin and all, osteoodontokeratoprosthesis is indicated. If you have gone through literature that alpha-Cur is a good tool, but it is not for dry eye because alpha-Cur acts only in wet eye. So what is the future of these mesenchymal and hematopoietic stem cells for corneal repair? I think we can get it done in future. And similarly, tracheal basal epithelial cells, and this is a similar phenotypic profile to limbal stem cells expressing P63 and P75. The big question is, how long donor stem cells remain viable on ocular surface of the patient? Only time will tell about that. Thank you very much.